These will be in listen-only mode, but if questions pop up throughout the webinar while the panelists are speaking, please feel free to enter them into the Q&A box in your Zoom webinar console, and we will address them at the end during the Q&A session. Our panel consists of 3 different experts, so I really urge you to take advantage of their time. Your speakers today are Dr. Amanda Heidemann, CMIO at KeyCare, Dan Exley, VP of Clinical Systems at Sharp Healthcare, and Dale Sanders, Chief Strategy Officer at IMO. Now, you may have all seen the title of this webinar and wondered, why did they go with a magic 8-ball? Well, these past few years have been packed with innovation and technological advancements, especially in the healthcare space. But with more data and increasing complexities that are now impacting patient data, we can't help but ask, what will come next for the future of healthcare? And if the quality of data doesn't lend itself to consistency or usefulness, predicting the future of the industry is about as reliable as shaking a magic 8-ball. I'm hoping Dan can offer some clarity by demystifying some of the industry complexities that are impacting patient data. Dan, can you elaborate what this looks like?
Sure thing, Megan. Hi, everybody. Great to be with you today. You know, for many years, for the past nearly 20 years now, we've had electronic medical records adding a collection of clinical data into the environments. A wide variety of clinical data on top of all of the clinical systems we might have had behind the scenes in lab and radiology and so on. So now we're 2 decades into collecting all of this additional clinical data, much of it unstructured, and that's been driving the adoption of analytic technologies. We have data warehouses everywhere now. It's table stakes. But something that's been happening around the last couple of years that I think is really shifting, accelerating the complexity and also accelerating the potential value that organizations can have from the data and the systems we're in our environments is the real world adoption and prevalence of standards-based interoperability. FHIR applications, trading between previously disconnected partners, a wide variety and growing of data sets, bulk FHIR coming and really starting to take hold. So we have more data flowing between previously disconnected trading partners within and between industry sectors, payer, provider, third-party technology vendor, no more information blocking. So that creates potential value, and it certainly adds complexity to the mix. I've looked at some of the data streams that are passing across FHIR payloads, and the mileage varies just like other interfaces, but I really like the ones that I see that come in from systems, and I feel a responsibility on our side as we share data out when we're asked that has structure applied to it. So whether that's a form of tagging, being able to send the bulk is certainly interesting, but that era that we're in right now, where it is real, and we are seeing that ease of interoperability becoming a reality, is just amplifying the problem, but it's also amplifying the potential for value.
Great first start to this webinar, Dan. Moving on, Amanda, I understand that quality data is part of reliable data, but are there other factors to achieving data reliability?
Yeah, I think one of the things thinking about what data quality is going to look like in 2023 is we have to make sure that our data is available. So we've heard for the last 2 to 3 years about all these ransomware attacks against hospitals and health organizations. You know, there was recently a group of hackers that actually apologized for hitting a pediatric hospital, but the reality is they're going to keep hitting these organizations. And if you can't get to your data, it's not very useful. I think it also poses a significant patient safety risk if people neglect the security side and the privacy side of how they manage their data. So for example, hospitals, if you're under a ransomware attack and you can't access your systems or you're trying to recover your systems, people are operating under their downtime protocols. And I know as a clinician who's been using EHRs for 20 years now, going back and writing paper notes or trying to find the information that I need based on a downtime recovery system and not being able to see things in the same views and have that data synthesized like I'm used to seeing it, it's definitely dangerous. And I would add a little bit to what Dan said earlier about the complexities of the industry. it's not just your EHR that you have to worry about being the subject of a ransomware or other attack. It's all the other systems that you may use. So people are integrated or interfaced with payer systems or state HIEs or immunization registries. If any of those are vulnerable, then that just kind of adds to the overall vulnerability. So, it's one thing to lose one system. It's another thing to be interconnected to other systems we don't control that are also at risk. So I see that as a big risk for 2023.
Certainly. And then Dale, I know you've talked about the 21st Century Cures Act and how that also played a role in this. Could you expand a little bit more?
Yeah, I think that one of the big tailwinds that will push data quality forward in 23 is the fact that patients now can demand access to their data in electronic form, right? And what they will see when they start looking at their data is how poor the quality is and how hard it is to understand. So, nothing like shining a spotlight on a problem to fix it, right?
That poor data quality comes in so many forms. Don't you think? I mean, we have patients who look at their open notes and say, wait, this isn't me. That's a simple one, right? More prevalent probably is, I don't understand what's in here, or this misrepresents something, or it includes information about a prescription I told them I stopped taking 3 years ago. I went in the other day and they had a prescription on there that I never filled a long time ago and still had it listed as an active med, even though using tools that are at our disposal, they could have known, never got filled anywhere. And I've seen them a couple of times since. So there's that sort of like poor curation. And then there's just the cruft within that. Or like if I look at 3 different sets of my open notes, or if I have my app on my phone and I authorize the connection and that third party hooks up that Fire plug and starts consuming that data, other forms of error, or even from that same health system, differences, right? They call things different things in different departments and different systems. As a patient, what am I to make of that? And also, what's my recourse? And if I'm trying as a health system on the provider side to be the most patient-friendly, engaging health system in the universe, that's creating further confusion and frustration would certainly be the opposite direction that I would want us to be pursuing.
Yeah, I think, Dan, that's a really good point about, what patients see and what their recourse is with their data. So, putting on my clinician hat, sometimes I wear the doctor hat, sometimes I wear the clinical informaticist hat. When some of the requirements of the 21st Century Cures Act came out, I understand those because I'm in the informatics role. And that's one of my challenges, is to convey what those requirements mean to the different clinical departments, whether it's physicians, whether it's nurses, whether it's other members of the care team, to make sure that everybody is educated as far as what is the data they're going to see and where is that data going to go. Because I think now more than ever, we have to think about who is the audience of this data, because we are consuming data from other people, but we're also sending data out elsewhere and making sure that it's readable and understandable. And I think we've seen such a big push lately on social determinants of health and being able to make sure that the data is useful to the people that are being faced with it. And let's face it, in the United States, we have fairly low health literacy. It's not been a priority. Public health has not been a priority. People have access to these documents that they don't understand. We still have physicians that are writing all of their notes in physician speak, and they may not even be aware of what the average reading level of their patient population is. So that's been a big challenge for me as a physician, is to educating other physicians and educating other end users of, what they can do. Can they use a stock patient education material that's, written at the 5th grade level and send that to the patient versus, pasting in their custom, narrative or phrase that they've built. It's something for us to think about and how we present that to the different audiences.
You're reminding me of my wife had an MRI on her neck recently. She had a gymnastics injury that's starting to plague her. And the diagnostic report from that MRI was, there's no way a typical run-of-the-mill patient could understand it. Now, we're lucky in that we have worked in the healthcare industry long enough, we can figure out how to translate it. It wasn't even easy for us. But the diagnostic report was about that long, but the real message to the patient could have been about that long, right? In essence, there's nothing really to worry about, right? And and getting right to the point. So I think your point, Amanda, is really well taken. Like as we move into the broader ecosystem, I think it's super important that the folks that are entering data, especially patient-related data, have to understand it doesn't stop at the HR anymore, right? There's and it's not just about billing and reimbursement anymore, and it's not just about quality measures anymore, right? There are these other consumers who need to understand and will be scrutinizing that data. So it's going to be interesting. Hey, before I forget, there's one other tailwind that's going to push things forward in 23, and that is the big announcement that came out of the CDC yesterday, right? So Dr. Walensky is really changing things up at the CDC to organize the data strategy that CDC has always had a challenge addressing. And so what I think we're going to see is the CDC pushing data standards now in partnership with ONC, right? Because our push on interoperability data standards is kind of stuck in limbo right now. CMS was pushing it for a while. ONC was pushing it for a while. With Mickey Tripathi there and with Dr. Walensky, I think we're going to see a new emphasis on data quality that we've not seen in the last few years.
We go like this, right? So it took a lot of activation energy to get these systems in place to even collect data in the first place. Good data or bad data, better than paper, knew where the decimal point was, et cetera. But then we have, whether you want to use the hype cycle or just in general to know that we vacillate through these sequences. And now where we had all this data, but none of it could be communicated easily with each, between systems in-house or between organizations of a variety of kinds. So now we add activation energy and say you have to be able to support standards, and there's incentives and carrots and sticks.
Mm-hmm.
Now we're at that point where it's sort of a bit of a disillusionment around, well, now I've done that, but it seems it's overcomplicated, or maybe the value is not created instantly when I plug in the plug. What is one of the main drivers for that is, well, the variety of data quality that comes across the wire once the wire is established. And then other forces like, who are those actors that are participating on the other end of the connection, and what are they trying to do with it? And do they even know what they're doing and how they do it well? So that might cause further confusion. If it's a consumer-facing app, there may be an intermediary that's helping bridge the gap between trading partners. It's not so great at what they're doing because it's all nascent largely. And even, our large commercial payer partners have challenges on their side too. For, decades, we've had one perception on the provider side of, the payers have all this data that we don't have. And that was true. They had data that we didn't have. But so often when you got close to them and started building partnerships, whether it was a ACO or something like that, you got to see, well, it may be a large national healthcare insurance provider, but they're segmented internally as well. They have old systems too. They have interface issues also. They have some of the same problems. So they've been working to solve that themselves, and others have been filling the gap. But now we're at this point where we're seeing, okay, data's flowing, but I'm still not in nirvana yet. What shall we do next? And invoking some standards that really help to improve the nature of what goes across the new wires is going to be where we'll spend a lot of cycles over the next couple of years, I think.
So Dan, I actually want to stick with you because I think you teed up our next question perfectly with people are like, why am I not in nirvana yet? A lot of organizations are focusing on their tech stack investments. Can you speak a little bit about how they can leverage them to normalize their data and hopefully overcome some of these challenges?
Yeah, I think organizations who choose to can make significant progress in improving the nature of their data quality with some of the basic descriptive analytics tools that they already have. They have something from Microsoft or Tableau or Qlik that allows them to look at data. Excuse me. They've also probably invested in some in-memory platforms that allows them to spin up the whole data set, a few billion records. And now you can profile those visually on the fly to get a sense of what is it that I have here. And that can be done relatively automatically with a bunch of tools. Now it doesn't cross the distance of now, how do I take my very messy, dirty data warehouse data set and now run all of my trusted KPIs that I give to the auditors off of that. But if we want to say, how do I get more people using it and have more ability to start asking and answering questions, being able to relatively easily interact with the data with like a light model set on top of it is something that organizations can use to start to build the understanding. It's been a long time now, maybe almost a decade since I gave the CFO of an organization I was working with the link to go and use a data exploration tool for all of her financials. There's a raw data kind of rolled up in a few different ways, but we did not go and build her a complex set of dashboards. We empowered her to see the nature of the raw data itself. We also caveated that by saying, don't go and show this to an auditor. Don't take this to the board. We can use this to build a thing that we can put more scrutiny on that puts it to be like a hardened KPI that you can now take to the bank, and it does exactly the same thing every time. But what that did was A, empower her to ask and answer questions differently, and then B, enlightened her to the nature of the data that she had underneath our hood, her hood, which was complicated and messy. And it made it easier for her and others on her team to give us the business rules to say like, oh yeah, for a while we did this thing because the regulators required us to, and then they changed their minds and put it back. But be sure to include those in this bucket over here when you count things like this. And they've never been able to do that before. When a doctor came and insisted they were giving them all the volume that they wanted to, she didn't have to call anybody and wait for a turnaround. She just pull it up and be like, it kind of looks like you've been declining a little bit over here, or we didn't see the bump that we thought. You know, it's not perfect, but was it that championing that? I've been in big data quality improvement initiatives and data governance and data stewardship without that light going on at the top saying, oh, we could do so much with this, except I see why it's so hard for you guys to be able to go and do something with this for me, why it takes so long to turn around a dashboard, or why so-and-so doesn't trust this. There's an issue here. Now I can have that person come in as a sponsor for data quality improvement work and say, whatever it takes, let's figure out how to do this. We need to build a rule to define things retrospectively so we can get value out of it. Do we need to change a process so that people uniformly collect the data in the front end? Do we need to build consensus around limiting the list of values people can choose from to be something that's at a minimum standardized, maybe not a folksonomy and more of a taxonomy, aligned with an external standard? I think, so that's just one example of where we put a lot of money into BI tools. We spent so much time like build a dashboard for them, build a dashboard for them. We haven't really been as much focused on helping to build understanding with key leaders around why our issues are how they are, how our data is. And I think that's been one thing that now we could just pivot to that, and something everybody could take home and try and see what happens. It has to be messaged right, but that's been one thing that has been very successful.
Yeah, I think
Amanda or Dale, you seen other examples?
exactly what I was going to ask. It's up to you, Amanda and Dale. What do you got?
Go ahead, Amanda.
Yeah, I mean, I would say, I'm seeing a lot of people that aren't fully using all of the investments that they've already made. So, they've got a lot of capability, they've got a lot of data, they've got a lot of tools, and maybe they've only had that narrow group of people that has access to the data. And I really like your story, Dan, about showing that CFO their own raw data to give them an idea of what is the vastness that's out there and how they could potentially use that to solve their business problems. I think it's good for organizations to do a periodic reevaluation of exactly what the tools are that are in their tech stack and how they're using them and if they're using them at all. So, we've seen things that have been kind of pseudo sunset. Maybe they're only being used by one department. Maybe it doesn't make sense to keep them for everybody. And then the other thing that we've seen is we've seen a tremendous expansion in the capabilities of EHRs and health information exchanges. So whereas people used to have multiple separate applications to do a lot of different things to help manage and engage patients, for example, now that can be rolled up into functionality that's EHR adjacent or fed directly from the EHR versus some of the workarounds that we had to do before with file exports and imports and things like that. So I think it's just everyone should kind of look at that periodic exploration of what do we have? How are we using it? How can we use it better? Because the reality is healthcare margins are, at all-time lows. Nobody has any extra money to spend on this. We need to be getting every little shred of value out of what we already have to be able to carry ourselves forward.
I'm looking at this not as a tech stack so much, but as the data stack. So, for example, I used to be known for, how to design an engineering or a storage array for data warehouses, right? I could care less about that now, right? The cloud has largely commoditized what used to be valuable in my portfolio, which was sort of the hardware and the operating systems, and the databases and the indexes and all that kind of thing associated with data. But the truth is that's all pretty well commoditized. Data pipelines are commoditized. They're getting better all the time. But what we haven't addressed well in the data stack that sits on top of all that infrastructure is the terminology. I mean, that's why I joined IMO when I came out of kind of semi-retirement, was to see if I could do something to push the industry forward on reference data management and data standards from the left side of the diagram instead of downstream and the right side of the diagram. So I look at it as, what do we need to do in the data stack more than I do in the tech stack? And that data stack starts with standard terminology and reference data management. It's fundamental. And by the way, if anybody thinks that large language models are going to solve this, they're not. And we could probably have a separate, webinar on that topic.
We should.
Yeah. Hey, I would like to ask an unrehearsed question, Megan. Can I ask Dan and Amanda a question?
You can, Dale. I will allow it.
Yay. Okay, you guys ready? You don't have to answer it right now, but if you can, that'd be great. But percolate on it, and I'd love to hear your thoughts before we end today. So you're in charge of all healthcare strategy for the US healthcare system. Okay. And you have to identify 2 data quality priorities to solve in 2023. What are the 2 specific data quality problems you're going to solve in 2023 as the Chief Data Officer for US Healthcare? I have mine, by the way. I already know mine. I've been thinking about this forever.
I was just gonna say. I'll come.
You guys want to wait? You want to think about it? Or you want to try to
put
answer now?
it on the back burner for a couple
Okay,
minutes.
we'll put it.
Yeah, because
we'll put it-
I've got this mental list and now I have to figure out how to get it to 2.
Yeah, right. We got to do this. We have to do this before the change of administration, because you're going to get fired probably when some new person's elected. So you got to do something in this administration.
Be like Levitt and put the clock on the wall. We only got a few weeks left.
That's right.
One of the things, Dale, you were just mentioning about this sort of the data quality, and I agree about your perspective on the commoditization of the tech stack and the challenges that still remain and are difficult to solve. And we've never really invested, to the extent we've invested in the tech stack, we haven't invested in the data quality stack. People have bought data quality tools, but those tools have been crude and descriptive and deterministic models and rules engines. And so I'm excited that we do have newer capabilities that leverage the cloud and leverage AI to help us start to solve that problem. We still have good old-fashioned blocking and tackling and governance that can reap significant value and doesn't require further investment other than the time and the will to do it. And I think about that within an organization, whether you're a payer, provider, or other, where you have or could look to see how you have variability between systems where you wish that you didn't. What is the reason why you don't have one string you can pull in one model that talks to patient ID or result type and get everything else that's linked up to that from all the other systems? You probably landed that data in a warehouse somewhere. It's in the same DBMS or model even, but there's some reason why I can't get a global view of the business, that patient, that provider's activity in ways that are easily traversed. And a lot of that has to do with choices that we've made, or maybe it was, acts of, errors of omission with just letting people have the lab system describe it one way. There's a limited amount of interoperability that we did internally so that the HL7 interface would pass that message back and forth successfully. but the reference ranges are different, or I've got a different EMR with the affiliate down the road than here. And so those are things which, while we have other problems that I know we need to solve programmatically and with new tools, I do think that building an awareness for those of us that are in this headspace, and if you're on this call today, you're probably thinking about these problems. I think we have to make progress on both fronts. Identifying, this is, so again, it's not sexy. It sort of sounds like motherhood and apple pie. It's the same things we always talk about. But if we don't know who the business drivers are who are inclined to listen to this type of thing, who might help us make a difference in those areas where it's been the most challenging, if we have some real world examples of, like on the data side or on the IT side or on the analytics professional side, we know there could be value here, but we've never been able to traverse that gap because of X. Starting that conversation and seeing, can we standardize this data set or the way this data is captured? Can we make a decision about a global crosswalk that we'll all use when we're describing service line between facility A and facility B, or between company A and company B? It's little things like that that can help to start to move the needle, and things can start to cascade down into more detail. And then you'll come to those things where you say, this is a sizable problem. I need 3 terminologists on staff forever, or a new class of tools that helps me do the things that I might have needed 3 terminologists before. Kaiser was doing term mapping at a granular level when they implemented Epic in 2004 and building their own terminology system. They had a fleet of terminologists working to do that. And we're thankfully approaching the era of where the cloud compute enables and the AI models enable the replacement of the need for 2 or 3 dozen terminologists with crafty tools. But the crafty tools still need to be deployed in the context of business understanding, clinical understanding, and value props, and tying those things together. So we lead with the former before we get to the latter.
Yeah, I feel like the theme of what all of you were saying so far is like there needs to be a greater understanding and support across the board for all of this and all the different layers. One question I wanted to ask, if organizations are stagnant with their data quality, they're just stuck, they're not sure what to do next to make it better. Can any of you offer any tactical approaches that they can start doing to improve their data quality and get more confidence with it to like help drive their organization's future?
Yeah, I can certainly.
I don't think you go ahead.
Go ahead, Dale.
No, you go.
Oh, I was going to say, I think I mentioned this a little earlier, but it's really important to understand how users are interacting with that data at the point of care and how they can improve that. So we're still seeing organizations that have done some interesting things regarding interoperability, because as Dan said, talking about doing that mapping from organization to organization and making sure that that data flows seamlessly and normalizing the reference ranges and everything you need to do, that's hard work. So I've seen quite a few organizations that have spent some of their investment dollars using overlay strategies. So maybe they can see the data at the point of care, but it's not truly integrated. So that's what we see sometimes with, I'm a primary care physician. So I see, interaction with a payer system that's not really integrated with my system. I can see the data, but it's not truly coming in. It's not part of my chart. And we lose the richness of that data. So I think seeing what are people interacting with all the time that's not fully integrated, and perhaps integration will help push that forward. I think the other thing is understanding that when we talk to users about how they interact with the data, they're not going to remember everything we tell them right when we tell them. So for example, I'm a health system CMIO, let's say. We're going to bring on a new system. People are going to get a 7-minute training because we've discovered that, that's about as much as people can absorb. We do these little, 3 to 7 minute videos. We see a lot of people disseminating for training. And unless people continue to reinforce what data is available and how to use that data, I think that people forget about it, and you become truly stagnant because you're not using what you've deployed. You're not getting your return on investment. So I think one of the ways that executives can tackle that is making sure that the end users understand the what's in it for me about all that data. Interoperability, we have more data than we have ever had. We as primary care docs, I should not be ordering redundant tests. I should not be doing duplicative work, but we do it because we don't have the data where we need it, when we need it. And that just goes to drive overall healthcare costs. So I think even tackling, it's kind of the whole paradigm about how do you eat an elephant. we have to look at those little bites, and we're going to have to chip away with this. So as I'm thinking about, Dale's question about how do we prioritize two things for US healthcare, we are going to have to do a lot of chipping away and a lot of different aspects of it to get to it. There's not a magic bullet, but we can talk more about that.
Yeah, I think we actually have a question later that we can get into a handful of those aspects, so that'll be perfect. Dale, did you have any tactical approaches that you wanted to offer to the attendees?
Around the stagnation of data quality, you mean, friend?
Yes, and how they can be more confident.
Well, I would say that I would say that statement almost assumes that they have a data quality strategy if it's stagnant. The truth is they don't, right? I'm not aware of any healthcare executives at the C level. Like, there are chief information officers, chief data officers, chief analytics officers, CMIOs that are aware of this data quality problem. But as I look at the attendees of the meeting today, I'll bet you we don't have a single CFO or CEO that's attending this webinar that have any notion of a data quality strategy to inform their organization, which is a little bit crazy for me because I came from the Air Force and the National Security Agency, where there were these obsessive leaders about data and data quality and being fully informed about their mission. And the only excitement I've ever seen CEOs, CFOs really express about data quality in healthcare has been like US News and World Report standings and that kind of thing. And we've got to move down further into the granular data that really affects patients, their treatment, and their outcomes, and craft a data strategy around that and have some passion with it. So I don't think the data quality initiative is stagnant. I think it's non-existent. And it's going to take a fresh new view, maybe even fresh new leadership in healthcare before we see a difference in that.
One thing.
I'm not giving up, though. I'm not giving up. I'm not that cynical.
No. Dale, I've been participating in a number of conversations recently. We've got a really great senior executive team working to understand our current state and upcoming realities with respect to health equity. Broad, right? The reality is, and it was interesting to see how much education we were able to provide to help quickly raise the understanding with this executive team, how much is already being required of our health plan, our medical groups, our health system hospitals, with respect to a wide range of externally reported measurements around a generous definition of health equity or drivers of health equities or inequities. So you take some of the stuff that we were calling the social determinants of health data over the course of maybe the last 5+ years in broad conversations. That's a part of it, and there's so much more there. And also, there's a whole bunch of measurement programs that were no longer voluntary and went live on January 1st. So I think that is one area where organizations certainly are talking, but there's a new understanding that we're talking about not only reporting a new type of data for a new reason that's completely novel for most. We're also talking about the way that data is collected and reported being also something that's new and relying on data that may have been crufty for a long time at our organization, or not something that the leadership team necessarily had in their mind. The data quality of race, ethnicity, language data, for example, as one example. But the broad data sets around, access to care, access to transportation, income levels and your zip code, your education levels, your sense of safety, et cetera. All of that is opening the door wide for conversations about, well, how's our data there? How is that between systems there? How would we show somebody that in fact we do care about those aspects of our community's health and well-being broadly? And so that's been really exciting to be a part of those conversations and see otherwise previously uninterested, and I don't mean that in a negative way, but just it wasn't a driver of outcomes for them to care about the nature of clinical or other qualitative data about our patients. Now saying, we should have some standards around that. We should have a tactical working group that not, goes end to end. We need to educate our staff about why this is important and check to see if that competency is building up within them. Are they collecting it consistently? And do we provide standard tools aligned with nascent external standards to collect that. So I'm hopeful that things like that, which are also objectively those programs looking and at forcing health delivery side systems at least to address those. I'm hopeful that that will help to illuminate where there's opportunity and further governance needed, maybe drive some action.
Thanks, Dan. It certainly seems like there's some important mind shifts happening that hopefully will lead to more progress.
Can I add one more little comment of cynicism?
Sure.
You know, like, I'm super glad we're paying attention to equity of care, right? But the truth is, it's kind of trendy. And if we were doing population health the right way, health equity would fall out as a natural outcome. If you're really about population health, you would address health equity within that strategy. But now we're like shifting everything over to health equity, and we've taken our eye off of population health. Like, nobody's talking about population health anymore.
But when we said population health, we were pretty much just talking about alternative payment models and a lot,
Yeah.
is it a demonstration project? Is it something I'm doing with the payer? A group of my frenemies in the area go to one of the payers, we do something that's got a new brand name associated with it, and we call that population health. That was probably a misuse of the term. My cynicism on that point is age is old at this point. I feel like what we're really doing here is just changing the way that the dollars shift around. We're not scaling up differently. If you have a multi-billion-dollar health system in a community, it's probably not going anywhere anytime soon. Some organizations are taking notice of that and tying in with things like the noting that they're anchor institutions, and you've got the community-based asset development work that they could be doing to really make decisions. And some health systems are doing this. And like at Sharp, we've been purposely looking at what's our investment back in supply chain at a smaller scale in the community to build up the ability of the community to support itself economically. We could go get a big national supply chain provider for something, but we make a different decision and make sure that dollars are going back into our community. But we've been working at that for a number of years, and some of that stuff's complicated. I think it was University Health System, the Cleveland guys that did some big projects. There were multi-year projects with like how they were getting their laundry done. They didn't have a local medical laundry provider, so they had to do a multi-year project to have the local community college help them build the infrastructure of the business owners to build a thing and then hire a workforce and do a thing. And it cost them so much money compared to just having Cisco come and do their laundry. But those are the types of things that we could do, but it's so far afield from what we've been doing. But as we start to, maybe we'll start to see more and more of those things. But I wouldn't throw the baby out with the bathwater on the notion of population health. It might just be that what we maybe talked about as population health hasn't really been that. I know there are exceptions to all of this, and that's all well and good, but broadly, right, we haven't been moving the needle on national wellness metrics compared to the rest of the globe, for example, or things like that.
All right, so Amanda, I'm coming to you next. So on how organizations can improve their data to secure a better future for the healthcare industry, can you tell me how they can do that with standardization, terminology, NLP, all these buzzword topics that we're hearing about lately?
Yeah, I think one of the big things that organizations need to look at is what do they hope to do with their data? And I'm really glad we kind of wandered over into talking about population health, because as a family physician, like, we are the original population health people. Our specialty grew out of the idea of preventive health and helping people live healthier, longer, more productive lives. And it's been really hard to get traction around that over the time period that I've been in healthcare and even before. And we need to look at what we're doing with our data. And we also have to figure out how to balance some of the cultural issues we have with healthcare in the US with what we're going to do with the data. So I'll give you a good example. There's a tremendous amount of focus right now on the idea of ambient intelligence or ambient listening or virtual scribes, or, somehow we're going to try and make the clinicians' lives easier. Because let's face it, all the clinicians were burnt out after COVID. We're over and done with it. We want our lives to be easier. We're tired of just feeding data into the EHR. So people are starting to look at these strategies where we're going to make things better for the end user, but we may actually be sabotaging ourselves as far as the data that's available for clinical decision support to further help those clinicians, and also to be able to really see what the outcomes are. So, if we care about how our patients are responding to a treatment, we care about their opinions, we can't just dictate into a note or have our virtual scribe dictate into a note that the patient's doing great. We have to have some kind of, discrete data, some kind of objective data that we can use to mine that. So, I think organizations have to challenge themselves to figure out what is the right balance between those new strategies. Because if you're not taking that narrative note and processing it and meta tagging it and tying everything to discrete fields, that data is not going to be useful, and we're going to just self-sabotage. So I think that's one thing that organizations need to look at, and try and figure out that balance. The other thing that I think people need to look at as far as what they're doing with their data is going back to like the earlier principles of waste. I talked a little bit about, the duplicative ordering. So, and this kind of ties into Dale's question of, how are we going to fix, the two big priorities of healthcare in the US? We have to figure out how to use that data and associate it with cost and tie it into waste, and understand, is the data that we're getting and the process that we're using it to get it, is it worth the cost or is it not worth the cost? So, and are we making it more expensive for us to render care, or are we able to do higher quality care less expensively? And I think until people have the data to understand that, they're not going to be able to move forward. So I can walk into a room full of physicians and they have no idea like what their unit cost to render, a 99214 visit in the office is. The physicians have no clue. The office managers have no clue. For the most part, if I walk into someone who's a retail entrepreneur, a small business person who, is selling something, they know exactly what the unit cost of that is. They know how much they're accruing to let it sit on the shelf. They are measuring that down to, the cent. And we just don't do that in healthcare. So I think we need to, kind of come to terms with that, tie the data to the cost, tie the cost to the data, tie the outcomes to the data, tie the outcomes to the cost, and kind of build this cycle where everything ties together and we can understand what we're really doing as far as value. Because I think that's what we're all looking for. We're looking for value in healthcare. We want our data to bring us value. But if we don't know what our data is, what has my data done for me lately? If I don't know that, then I really can't figure out where to go next.
Nicely said, Amanda. That was awesome, friend.
Agreed. Dale, I think that one of the answers has to do with to your national framework on data quality question. I don't know if it's data quality per se, but further work on transparency around cost. I realize this would require or influence upending some of our macroeconomic models in US healthcare delivery, but more insights so that a doctor and a patient did know the full scope of things. And there's been some work done on that, obviously, but more work there. And just the general, requiring organizations to, generally speaking, leverage the interoperability options at their disposal to limit or reduce the waste that was just mentioned by Amanda. Tremendous. I mean, my brother literally just texted me last week and said, my friend needs to get a second opinion for something, but even though they have an appointment to see her soon, they can't see her until like 3 weeks from now, because that's the earliest they could reliably get a CD with the imaging study results from brand name health system right down the road X. And she was saying, no, it's a critical second opinion she needs. She was like, can I drive down to the department and get a CD and bring it over to you? And things like the patient's having to go and solve that problem. We have the technology, but we don't have a uniform adoption of that technology. As a friend of mine said ages ago, a standard is only as good as its degree of adoption. So it could be good, but it doesn't really matter. And so that enforcing more of the interoperability at a granular level broadly will be required in order to solve some of those things nationally.
All right, this question may tie into Dale's question earlier, but what do you think is one aspect that is going to be the most crucial to improve over the next 5 to 10 years? And how will data play a role? So before, when we were doing our prep, everybody picked out a topic. So I'm just gonna call on you and tell you your topic and then dive into it. So Dale, can you tell us about how AI will play a role?
Well, AI is going to play a big role. The problem is we've been trying to do things with AI that are beyond the capabilities of our data. So, we're sort of equating what we can do with AI in healthcare as if we've got the same data that has been built up over billions and billions of miles of autonomous vehicle driving, right? We just don't have very good data to feed into AI right now. And so that's not to say AI is worthless. We just have to adjust what we think we can do with it and how we use it. And a good example is when I was at NSA, you couldn't imagine a messier data environment, right? I mean, it's just talk about non-standards. There is no standards in the NSA environment. So we used AI there to generate hypotheses and patterns in data that then you'd sit back as an intelligence analyst and you scratch your head and you go, well, I think there's something to follow up on here. But it was a hypothesis generation tool. We weren't trying to actually predict anything specific. We weren't trying to be too precise because we just recognized the data was too unreliable to do that. But it was a great tool for accelerating hypothesis generation, like so that you weren't wandering around up here in the unknown space of what's going on. You'd use those pattern recognition tools and clustering techniques to say, I think there's something happening here. Now let's drill into it. So AI is going to play a big part, but we have to fix the underlying data content, data quality issues, data completeness about patients in order for us to achieve what we're trying to achieve now.
I'm excited about how even that directional guidance will provide a lift that improves the efficacy or the true productivity of professionals working top of license, whether that's a physician or an analyst or a CFO. Something that might have taken a week to do might take a couple of days to do if
Right.
some of that blocking and tackling and data munging is reliably done by a bot. And as long as you can look back and it's not fully black box maybe, or there's enough trust for the given use case, this isn't prescriptive yet, but
Right.
if it's providing an assist, can that help with our overall workforce requirements? Or just to your point, not be sort of like, all right, new data set, what am I doing here? But say, all right, I've organized this for you. Even things like, Epic's made a lot of press with their patients like mine thing that they're doing with their billions of records in their cloud-based data warehouse. We're a long way from saying prescriptively, here's what you should prescribe for this patient because this has a digital twin set over here and the stats have run. We're so far from that. But I think it will be assistive to physicians in coming years to at least have a reference point to say, did you know you've seen 4 of these over the last 10 years? But here's something to think about here. We've organized the data about 400 or 4,000 of those from a global cohort, segmented it right, and that just helps that clinician be more accelerated in their differential diagnosis process, or you name it, even while we're well short of something that's fully prescriptive.
If you look at how AI is accelerating the understanding of protein folding with AlphaFold, that's a great example of the right way to apply AI, because it's now taking what used to take years and years in the lab trying to figure out how a protein is going to fold. And through AI and clustering, essentially, it's narrowing that down and saying, we think, with AI, with AlphaFold, we think this is how that protein is going to fold. Then you take that hypothesis into the lab, right? Mm-hmm. So you're not wandering around up here anymore. You're kind of wandering around down here, which is a lot narrower. So that's the paradigm. That's the mindset we have to start taking with AI in the clinical data space right now.
Thank you for that, Dale and Dan. Amanda, going to jump over to you. How will data quality play a role when it comes to our labor force shortage?
Yeah, I think, the shortage of clinicians is not getting any better. And it's still going to be with us for the next 3 to 5 years. There may be plenty of people coming out of training, but, they're not as experienced and seasoned as some of the clinicians that we lost. And I think we need to look at how those end users are interacting with the data and how do they want to interact with the data? Because I think we've kind of gotten into this rut of, because this is how EHRs are built and because this is how point of care systems are built, this is the way it has to be. And it may not always be how people work best, and specifically not how they work best to care for patients. So there's one healthcare system in the Midwest that actually launched this as a pilot in 2022, and now they're rolling it out more broadly, where they actually created teams that have in-person nurses and virtual nurses. So looking at using that to create kind of a triad of folks caring for the patient, where one is really focused more on the data. They're more focused on the cognitive things, and communicating with the patient, communicating with the family, communicating with the other caregivers. And then the other two caregivers are actually at the bedside, and they're focused more on the assessment and kind of populating the data, and responding to the person who's kind of crunching the data. So rather than having one person trying to synthesize all of that and provide all of the care for the patient, they've allowed that to be specialized, which has actually extended the workforce. So for example, nurses that are older that may have physical limitations, they can't lift and turn patients anymore. So they were going to fall out of the nursing force. Now they're able to move into those virtual roles and become, a different kind of scientist, a different kind of nurse working with the data versus being right there at the bedside. But yet all the virtual technology lets them be right there with the patient in a different way. So I think we're really going to have to look at that. We're going to have to look at the labor force, what we can learn from our labor force about data. What can we learn about absenteeism rates and time off and things like that are a little more cut and dried that we can use to inform how we roll forward. I think those things are all going to be critical.
You just reminded me of, I used to talk about a digitician, right? And it's basically the intelligence analyst for the care team. Kind of what you just described, an interesting new place for nurses in that role, right, friends? So that they're really managing the data associated with the patient. They're synthesizing that and they're presenting it back to the care team. So the care team doesn't have to do that, right? Interesting.
All right, Dan, last part of this question is coming to you. Talk to us about democratization of data.
Well, I've mentioned already this morning a few examples, the CFO for one, any number of dashboards that link and drill down through to granular data, even when it's something that was a heavily engineered dashboard, instead of having pre-baked measurements, having those be calculated on the fly through some of the technology investments that we've done pure play. Broader access to the actual raw data itself creates conversation and creates opportunities for further improvement of the data quality, that a realization of the awareness of the issue. We've talked about how patients, by extension, their families and friends and loved ones who are looking at their own data at scale for themselves for the first time ever and being able to be a stakeholder in that. We're talking about, the executive teams that are for the first time seeing the nature of the demographic data collected at registration. We have enough every day, every claim. We've pretty much got enough data to get that claim out the door and get it paid. That's been good enough. Now, when we need to know the granular bits within that and the nature of the quality of that and how often they be other/unknown or unasked. Who let unasked be a value in the pick list you can pick from for that data element? Somebody at some point. Nobody at a decision maker level had looked at that field lately and wanted it. Now we can have it. So we're seeing it, on both ends of that, and then all in the in between, the physicians and nurses and other caregivers having insight into that, the interoperability that we're seeing. So that broader use of that data, even in its current messy state, has great value and will drive action. In a lot of cases, though, because it generates some heat, that's okay. We can channel that energy in productive ways. And it's all in how we frame our thinking about the nature of this data, how we got to there and how we could get to someplace better that will allow us to channel that heat in the productive direction instead of letting it sort of broadly diffuse or fester in a single pot.
Solid answer. Big thank you to all of our speakers. At this time, we're going to kick off our live Q&A session. Attendees, if you have any questions from today's webinar, and I'm going to gently remind you, you have 3 experts at your disposal right now. If you haven't entered your questions yet, do that in the Q&A box in your Zoom application. And then just please excuse any brief silence from our team because we will receive, review, and then answer the questions as they come in. But now is your time to pick their brain.
I got to hear the answers to my question, man. Come on.
All right, Dale, you can fill the silence then. You guys can do that while everybody types in their questions.
I'll jump while questions are coming in. So I mean, I think, I talked a little bit about population health. I think if I had to pick two things that I need to prioritize as far as how we're going to help use data to solve the mess that is US healthcare, I think we need to have some sort of unified data that rather than gathering it from research studies all over the place, we need a centralized system where we can truly understand the health of the population. I know there's a lot of hot discussion about universal health IDs and people want it, people don't want it, but I think we need to get a better picture of where we are to be able to figure out where we're going. So, what is obesity doing in the US? What is diabetes doing in the US? Because really those things, those are driving the costs of healthcare, and those are the things that's going to bankrupt the economy if we don't address them. So I'll throw that one out, and then we'll leave some time for Dan.
A national health census data.
Shocking. I know we've been talking about it for like 20 years.
Yeah, I think, my prior thoughts around sort of additional carrots and sticks for the broad adoption of interoperability of clinical data for purposes of improving quality of care, whether it's the results coming back and forth or the reduction of waste and the improvement of efficiencies by having just an awareness of what's been done elsewhere. That's something that's well within the scope of what could be done by regulatory bodies. But I haven't seen evidence that that's been making its way out to the edges.
Is that your final answer?
I think so. For the moment, I'll call you next week when I remember. When I find, give me a few cycles to sleep on it.
Well,
so I brought my magic 8-ball. We're going to ask: will healthcare be solved in our lifetimes in the U.S.? And the 8-ball is optimistic. It says, "As I see it, yes."
No cynicism in that 8-ball.
No cynicism in the 8-ball.
Whose lifetime? Because I think I'm older than you guys.
Dale, did you answer your portion of the question? Because we have a couple.
No. So here's my answer to the question. I get three responses since I asked the question. So we have to do something about patient identity, and I'm not suggesting a government sponsored ID because I don't think that's ever going to fly. There are commercial alternatives emerging for that. So patient identity, lab orders and results, because it's so fundamental to understanding what's happening for outbreaks, things like that. Loic, in my opinion, is a total disaster as a terminology. It's not working. And the final one is that we've got to improve our clinical notes. We have more and more dependence on those clinical notes. But Amanda, I bet you can testify, friend, and I've looked at it too. Those clinical notes are not the holy grail of data that we think they are. And so those are my three choices right now. But I really like Amanda's national health census assessment. That's really interesting.
There's ways that organizations could aggregate that information and contribute the aggregates. That's solvable.
Yeah, but the problem with that, though, buddy, is the data that we have in healthcare delivery right now is heavily biased. But if you took a census approach to it and you collected that data with digiticians, I think you could eliminate some of that bias that we have in electronic health records data right now.
Mm-hmm.
All right, team, I'm going to jump to an attendee question just to make sure that we answer theirs. In your opinion, are data consultants worth the cost, or is it more valuable to tap into your current staff or end users for your current EHR system?
I suppose it depends on the cost. I've been very successful in using external parties to come in and help show the way, right? There's two different ways. It depends. Are you underway and you know clearly what needs to be done? You just don't have enough hands, and financially you can get more hands. Great. I've never been a fan of jobbing off the things, but to Dale's point, so many organizations don't really have a strategy around their data quality, don't know where to start, don't have that practice. If there's a way to get somebody to help with being a sensei or doing wayfinding with practical examples and not just deploy a program that nobody adopts, probably money well spent. But you want them to be teaching your staff how to do it, right? So that they can leave soon, and then you guys can be self-sufficient on your own. Amanda or Dale?
I'm gonna steal that, that title. I want my next title to be Data Sensei.
I have a job description for a data strategist. And after I wrote the job description, I thought it's like a 20-year point to get there. So data consultants can be really good, but it depends on who you get and what kind of experience they have. Yeah, they can give you that outside view and they can kind of move you along. But like Dan said, you've got to eventually have that yourself. That's
The best ones for something like this type of work are the ones that would be able to be buddies and trusted by your CFO and your CMO as much as they could be trusted by your CDO and your CIO.
Yeah, right.
All right.
I think that wraps it up for our questions. I want to thank all of our attendees, our panelists. We hope that you found the information in today's webinar useful. Be on the lookout for a recording of this discussion. And if you want any additional information regarding IMO or IMO solutions, please leave the magic 8-ball on the shelf and just contact us at sales@imohealth.com. And everybody have a great Junior Friday.
Thanks, Dan, Amanda, Megan. Thank you. Really
Thanks,
appreciate it.
everybody. Bye.
Bye-bye.